Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. In the name of Allah, peace upon all of you everywhere, and good afternoon, good evening, and good morning in Mexico too. It's my honor today and my happiness to conduct this meeting in Hussam Ziada Grand Round Zoom room, which is interested in the teaching and conducting the knowledge about the anterior segment surgery, whether the cataract surgery, cornea, and refractive surgery. And we are today conducting this meeting about the non-phaco modern cataract surgeries, because all the people today are talking about the phaco and about the newer phaco machines and the smaller incisions with the phaco and so. But we are coming back, I can say we are coming back from the old technique, which I have done 12 years ago here in Egypt when I was an assistant lecturer, or at the end of my residency. I have done a small incision cataract surgery, and it was very, very good and amazing technique for me at such time. And after I mastered the phaco and have become a grown-up surgeon, okay, and also I am a treatment now for the phaco surgery, but I'm insisting all the time to say that the phaco surgeon should be fully equipped, can do the old techniques, starting from the extra cap, going to the small incision and the phaco too, because if you don't have the old techniques and all skills in the cataract surgery, you may be stuck. You may be stuck in some situation during the surgery, and at this time, you cannot solve your problem, and you will lose a lot of challenges, and you will lose a lot of solutions which may be learned or may be getting from this experience. So today we will start talking about not the extra cap as a classic technique, because I think everybody knows the classic extracapsular cataract surgery, but we will talk about modern extracapsular cataract surgery and then the small incision cataract surgery. So let me to introduce my dear colleagues and professors, my dear guests today in this meeting, and I will introduce them in the order of speech. I'm honored today to have Professor Dr. Ahmed Mustafa, Professor of Ophthalmology at Mansoura University, Egypt, and he is the former president of the Egyptian Ophthalmological Society and the present board member of the very old. I can see it's older than the old India, because the Egyptian Ophthalmological Society is from 1902, right, Dr. Ahmed?
Yeah, 19.
Yeah, okay, I think it's older than the old Indian Ophthalmological Society, which is the largest and the biggest society in the world of ophthalmology. And Dr. Ahmed will talk about the capsular surgery, the different techniques of the capsular surgeries in the old techniques. Also, we have today an honorable guest, Dr. Boramani. Dr. Boramani is a very good and talented teacher and surgeon, cataract and cornea surgeon. He is executive chairman of the International Society of the Manual Small Incision Cataract Surgeon. And Dr. Boramani will talk about the construction of the scleral tunnel, small incision cataract surgery wound, how to conduct the scleral tunnel perfectly to get an easier and successful surgery, a small incision surgery. And Dr. Boramani from the Navi or New Mumbai, India. Also, I have my honorable guest, Dr. Carla Pamela from Mexico. He's anterior segment surgeon, cornea, cataract, and refractive surgeon, and he's a very brilliant teacher and surgeon too in the Institute of Ophthalmology in Mexico. And she is the host of the training programs of the manual small incision cataract surgery too. Dr. Carla will show us today a different manual small incision cataract surgery cases with different scenarios and difficulties. Also, I'm honored to have today Dr. Rakesh Shakya. Dr. Rakesh Shakya is my dear friend, and he's a very good surgeon, and he is the director of the glaucoma and the cataract services in Chitrakoot Hospital, India, too. Hello, Dr. Rakesh. And Dr. Rakesh will show us today a different and difficult cases with manual small incision cataract too. And he will show us today the fastest small incision cataract surgery in the world I have seen in the world. And finally, I will talk about the modern X-ray cap, how to do X-ray capsular cataract surgery just with one stitch. Even you have a big incision, you can do it with just one stitch. If you plan for an lamellar wound, how to do it. If you are stuck with it, with this situation, you can do it and keep it with the least stitch, even with no stitches. It's a step. It's just a step going to the sutureless non-phaco surgery. And finally, I'm honored to have the founder of the International Society, the founder and the chairman of the International Society of the Manual Small Incision Cataract Surgery, Professor Amorio Saho. He is a man behind all these activities and behind all surgeons of the manual small incision cataract surgery. So I am so honored today to have you, sir, as a panelist in this meeting. Also, my dear friend, Dr. Sitanshu Mathur, is the man behind the scene, as we are saying all the time. And he's the joker and the man behind the scene in all activities of the surgical skill transfer courses and society too. Hello, I'm honored to have all of you today. And finally, I'm pleased to have my dear and brilliant president, Dr. Ambradi, resident of ophthalmology at Al-Azhar University, and Dr. Amr, or Dr. Amr in the Arabic pronunciation. He can do the all cataract surgery in the all techniques, X-ray cap, small incision, and phaco. He and all other our dear residents in our groups can do the all techniques now. So I will not talk, I won't take from the time of the meeting, and asking Dr. Ahmed Mustafa to start his presentation now.
Okay.
Okay, sir, I will stop my sharing. Yes, sir, please start sharing your screen.
Good evening, everybody. Thank you for Dr. Hussam for sharing for such a meeting. For me, capsular surgery for extra cap, I all the time learn the beginners how to deal with the capsule, because the problems, all the new generation are in hurry to learn phaco emulsification, and some much problems and complications already suffered during surgery. So I first, how to deal with the capsule. For the capsular surgery,
Dr. Ahmed,
I learned.
Dr. Ahmed,
Yeah.
did you start sharing of the presentation itself?
Yeah, see. Can you see it now?
No, not the presentation, not the PowerPoint, just the old videos, the page of the old videos together.
No, just on my screen is the capsulotomy. Can you see it?
No, not yet.
So how to?
Again, as we did before, to
Share and reshare again?
share again, yeah.
Okay or not?
Okay, starting to, yes, now we can see the capsulotomy now.
Already okay?
Yes. Yes, sir.
Can you hear? Okay.
I can hear.
First of type of capsulotomy is can opener technique, and for the perfect can opener technique is nearly the same as capsulorhexis. But for the beginners, just to have such technique would be problematic in the sub-incision area, how to complete the can opener, and also the capsular tags present will be difficult during problematic during delivery of the nucleus, or IA may extend such or capsular tags to the posterior capsule. So I recommend for all the beginners just to start with envelope technique. For envelope technique, just to fold the anterior chamber viscoelastic, and then with bend needle or cystotome to have such horizontal incision in the anterior capsule, and then as hydroluxation or manual dissection, delivery of the nucleus, then IA intrabagal, and then full of the bag with viscoelastic and IOL insertion and dialing of the IOL, and then just one incision, nasal and temporal, and complete this to have the anterior capsulotomy. For the instruction course, I can explain them for this silicone paper and how to do the incision in the capsule. This silicone paper on the mug or cover, and use the scissor, and how to deal with the capsule, just to hold the capsule from near the tearing edge, and all the time to complete for this sharing movement towards the center till complete the capsulotomy. In such a step, the beginner just learn how to deal with the capsule. This is my first cases of extra cap with use of bent needle to have such capsulotomy. This is start as the envelope, and to complete this incision, and we can pull the upper anterior flap towards the section, and then hydrodissection and the rotation of the nucleus. Then with the use of viscoelastic, we can deliver the nucleus. After that, intrabagal irrigation aspiration to complete cleaning all the cortical material, and insertion of the IOL intrabagal. We can see the edge of the envelope. And then we can use the Vanna scissor after dialing to have the incision in the capsule. Here to demonstrate the lower part and the upper part of the anterior capsule. This with the Vanna, just small cut, and use either capsulorhexis forceps or the forceps just to complete it. So in such a case, just got how to use the capsule to cut in circular manner. After that, I use the needle, insulin needle, as super blade not bent needle. And just to have a cut from nasal to temporal, this will be clean cut and also less problematic other than the bent needle with tips of capsular bags can be problematic. In case of hyper, it is easier to have the capsulotomy. Also, in case of cataract subluminescence, it is easier with the needle to have also the capsulotomy. Will not complete the video, just the start, and will hit the level of the nucleus cataract process. Also with white cataract, we can use such method, this envelope technique, very safe in such cases. And also in intumescent cataract, we can deal with the same as envelope technique. Would be much easier for the beginner to how to do such a capsulotomy. Some cases like that with small pupil and you don't have any way of dilatation or iris retractor, so can use here envelope technique safe for such cases. And you can deliver the nucleus. And you can see here the envelope, and you can implant your IOL and then to do the capsulotomy. Just one snip and you can complete it. This is the envelope technique. For doing capsular access, all the time I learn the junior staff how to create such continuous curvilinear capsular access. You are using cystotome or bent tip of needle of capsular access forceps, and all the time you have to have a very good radar reflex and to adjust the eyepieces of the operating microscope and try to tilt either the patient position or the head to have a very good reflex so you can work it really easy. Here from Caesar and Benjamin from United States, from UK, they also all the time they recommend you have to pierce the center of the capsule, then you can split radially and just to lift the capsule to have to create a flap, and such a flap you will just be folded on the capsule, and by the chaining power you have to complete the rexes all the time. Your movement will be towards the center of the pupil. Here ممكن to start with capsular rexes and then complete also with forceps or with the bent needle. For practical training for such, the same as we had done in envelope technique, we can use the same pierce, split, and elevate to lift to create a flap. And with the forceps, all the time you have toward this movement toward the center, and better all the time to have such movement from near the tearing edge. Stop and again from the tearing edge till you complete your rexes. Here is another way, the same, but I got one mistake. Just I move, all the time I forget, so it will be an extension of the rexes. So I have to stop and start again from near the tearing edge to have it complete to a good rexes. After using this, I the same paper on under the microscope. Pierce centrally, split left to create a flap, and with McPherson hold it, and all the time near the turning edge, and this circular way also toward the center, so you can complete your rexes. So I asked the residents to do a lot of such rexes on the paper. Now we can try with another way for practical training. Just we have this cherry tomato, also from Caesar and Benjamin from UK, just to put this cherry tomato in boiling water just for 10 seconds. So you have little bit hard and thin, pierce centrally and split radially, left to create the flap, and then all the time on this fold, this flap so, and the movement toward the center till you complete your rexes. Some cases, if you put this cherry tomato on more time in boiling water, will be soft, and that will happen. We do so with high pressure inside, and then we put this Argentinian flag sign. You can use also black grape to learn for capsulorhexis. The same way to have pierce centrally, split, and to do this just to create flap. And here you have fluid inside, so you cannot use the bent needle. So you have to use the forceps, capsulorhexis forceps, to complete your rexis. And all the time you pull it on direction of the center till you complete your rexis. So you can here with the needle in cases of hard cortex, but in soft cortex will be this much better. Okay. You can use capsulorhexis forceps, and if you want to use the needle, answer needle, just have the first bend near the base, and then the bevel will be on the left side. This is the right one. On the right side, this is long, and we cannot see the tip of your needle during your rexis. You can use McPherson if you don't have capsulorhexis forceps to complete it after initiating the flap. Here a case, just pierce centrally, split radial, and then elevate to create the flap. And all the time you can see the flap with the movement. I recommend for the beginners here in the area of sub-incisional area to have to inject again viscoelastic to identify the edge of the rexis and complete it either with the needle or with the capsule forceps. And in cases of white cataract, you have to use capsular steel to have the same steps. And just when you have got the flap, you can use the needle or the forceps to complete your rexis. All the time, I insist to learn the beginners how to deal with the capsule. And this is the problem. If not completed, you cannot complete phaco if you need to work as a phaco surgeon. we have the venous, either the curved or the straight, just in case we need to enlarge the rexus, we can use the curved one, not the straight. The curved will be either, if any extension will be in the direction of the rexus. But the other side, if there is this, can extend the posterior. Here, in cases with larger nuclei, we can do just the same as the rexus, but we cannot deliver the nucleus from this small rexus. So after we finish the rexus, also pierce centrally, split and left to create a flap, and move all the time toward the center to complete your rexus. And for all the beginners, don't be in a hurry in such step, otherwise the case will not be completed. Also, inject viscoelastic at here to just identify the edge of the rexus, and then we can complete again either with the forceps or the bent needle. After completing the rexus, in such a case, and removing of the anterior capsule, with the same bend needle, we'll have two release incisions, and this two release incision will be easier during the delivery of the nucleus, so there will be no problem with this small rexus. Now, IA, intravagal, clean all the cortex, and you can see now this two release incision, and then you can implant your IOL. For any questions, this is my email, and thank you very much for your attention.
Thank you, Dr. Ahmed, for this nice and guiding presentation about the all situations of the capsular surgeries, either in the extracapsular, the envelope, or the capsulotomy techniques, or the rexus techniques in different situations, from the ease to the difficulty, and also it was interesting to show how to do the capsular surgery at home. Now, especially we are staying home now for the beginners and for the seniors to not to lose their skills, to do the rexes on the tomatoes and the other fruits at home. Thank you very much, sir. And I'd like to postpone the questions to the end, not to waste the time or to interrupt with the other presentations. At the end, we will collect the all questions for the all speakers and discuss with them. So I may ask you, sir, just to stop sharing.
Okay.
Yes, sir. Thank you. So I will announce about the questions because of the chat is disabled for security reason. So I may ask all our audience here to send the questions on this page, Ziada Academy. It's a Facebook page for the scientific issues. So you can send message your question on the message of this page, and I will collect all of them, and we will discuss all of them at the end. So now, sir, I may ask Dr. Brahmani to start his speech about how to do perfectly the scleral tunnel for the manual small incision surgery. Please, sir, start your presentation. on the other side. Dr. Brahmani, do you hear me?
Yeah, can you hear me now?
Yes, okay.
Can you see my screen?
Yes, now it's full.
Yeah.
Let's start, sir.
Yeah, it's a full screen now.
Yes.
Basically, I'm going to speak on two topics. The first is the principle of constructing the scleral tunnel, and my second topic will be the Blumenthal's mini nucleus technique and my modifications in the technique. First of all, let me thank Professor Hosam Ziada, the Egyptian Ophthalmic Association, and the Egyptian chapter of ISMSICS for inviting me for this talk. Now, I presume that the most of the audience is a beginner in SICS learning or the scleral tunnel building. So my talk will be very basic one as far as the scleral tunnels are concerned. Long back, almost 35 years back, we used to take an incision on the limbus, a very big incision. But round about say 1990 onwards, these were the initial workers who thought of approaching the antechamber through the scleral tunnel, and we can have a good sutureless incision through the scleral tunnel. So to my mind, these are the two greatest developments in the cataract surgery which came around 1990. First thing is the sutureless cataract surgery, and the second one is the capsular invention of the capsular excision, because the capsular excision has made our surgery very safe, and scleral tunnel incision also is a sutureless technique and it can give wonderful results. I am doing a lot of advanced scleral tunnel techniques to manipulate or manage the pre-existing astigmatism, but today I'm not going to talk anything about that, but I'm just talking about the basic principles of scleral tunnel incisions. Imagine two rubber balls situated one inside other. There is a cut on the outer ball at one side and there is cut on the inner ball at some different edge. So the segment of the inner ball which is intermediate can act as a ball. So when the inner ball is pressurized, nothing can escape out. So this is the principle of the scleral tunnel. The two incisions are at different levels and there is a connecting tunnel in between, and the inner part of the tunnel, the lower part of the tunnel, acts as a ball. So this is how this incision remains a suture watertight incision. You can have a straight external incision and have a dissection and do a tunnel. So basically there are three parts. One is the outer incision, an external incision. Second is the internal incision from where you enter the antechamber, and the in between dissection is the scleral tunnel. You can have a curvilinear incision. The curvature can be parallel to the limbus, or it can be a straight one, and it can be in the opposite direction. If the curvature is parallel to the limbus, the end points of the incisions are very near the limbus. So because of the intraocular pressure, there can be considerable sagging of the wound, and there can be a lot of induced astigmatism. If you make the incision straight one, the sagging is comparatively reduced, and the induced astigmatism also is reduced. But if you make the curve in an inverse fashion, the tunnel also will be long one, and the ends of the tunnel, the ends of the external incision go away from the limbus. So the sagging of the incision is very less, and the induced astigmatism also is correspondingly reduced. The principle of incisional funnel is well known. You can have a liberty of taking a longer or larger incision. You go away from the limbus and you can have a larger incision without inducing most astigmatism. So this is the principle of incisional funnel. But if the incision is farther away from the limbus, the manipulations inside the chambers become quite difficult. And this is a concept of the Fron incision. So Jack Singer devises Fron incision, which is a curved incision. The central part of the incision comes nearer to the limbus, so you can have a good manipulation inside the antechamber, but the ends of the incision are away from the limbus. If need arises, you can extend the incision radially. These radial extension, they don't take part in any astigmatism. And instead of a curved incision, you can have an inverted V-shaped incision also, which is called as a chevron incision. Now, when you dissect the tunnel, initially you have to make a small groove on the sclera, almost about 1.5 to 2 millimeters behind the limbus. So this is the initial groove in the sclera. You form the external incision. Now you have to dissect the sclera, which is the dissection goes parallel to the sclera. So this is your crescent blade, and the direction of the blade is like this, which is a parallel to the sclera. But once you reach the limbus, you can see that the sclera and the cornea, they're not aligned to each other. So you have to change the direction of the dissection and go slightly upwards. So here you have to tilt your crescent knife also, and the blade should be now looking slightly upwards. But once you come, say 1 millimeter inside the limbus, now you have to cut straight away and enter the antechamber. So now here the incision has to be parallel to the iris. So you have to tilt your blade, make it, the handle, you have to make the handle more vertical, and the blade now becomes parallel to the iris, and you enter the antechamber. So this is the way the scleral tunnel should be dissected to have a perfect wall-like incision internal part, and this portion acts as a corneal wall, which prevents the seepages of the fluid outside, and this becomes a watertight tunnel. Now this is a small video. Now with a Bard Parker knife, we are doing a external grooving. This is the external incision, which is a front incision. Now when you do the dissection of the sclera, how to be sure that you are exactly halfway in the depth of the sclera? Now throughout the dissection, you should be able to see the blade in a semi-translucent way, so that you are sure that you are not going very deep and you are not very superficial. So once all the dissection is completed, tilt the blade, go into the into the cornea about 1 millimeter, and complete the dissection. This is another small video. Now here I am taking directly grooving the making the external incision with the crescent knife only, but a beginner should have a proper groove done with the blade, and then start the dissection of the scleral tunnel. The blade should be seen through the sclera. When you approach the limbus, you should change the direction of the blade and then do the dissection of the cornea. The dissection of the cornea is concentric to the limbus and almost 1 millimeter inside the limbus. This is the way scleral tunnel should be dissected. Now, what is an incision with the scleral pocket? Now, this is the incision designed by Professor Blumenthal from Israel. Professor Blumenthal uses anterior chamber maintainer. So this anterior chamber maintainer through a tubing is connected to the BSS bottle, which is at the height of about 60 centimeters. And there is a continuous flow of BSS into the anterior chamber. So this is a positive pressure technique. The globe is pressurized. So because of the pressure, the dissection becomes very easy. And there are tremendous advantages of using the anterior chamber maintainer. The Blumenthal's incision is a central incision, straight 4 millimeter incision. And now this incision has got 2 radial extensions on both the sides. So with the radial extension, then the scleral dissection is done. So this is a regular scleral tunnel. But what are the scleral pockets? Scleral pockets are the additional dissection. The yellow part seen on both the sides, this is the curvilinear dissection on both the sides to create additional pocket. What is the purpose of this pocket? Now the nuclear, for making the pocket also, you have to do the tip of the crescent blade for making the curvilinear dissection. Now the nuclear delivery in the Blumenthal technique is because of the force of the fluid. You have to pass a sheets glide into the scleral tunnel, depress the posterior lip. Once you depress the posterior lip, the fluid starts coming out. There is a positive pressure into the anterior chamber because of the fluid coming through the AC maintainer. So the nucleus slowly glides and it gets trapped into the scleral tunnel. So because we have done pockets on both the sides, this round nucleus gets trapped into the scleral tunnel, and then the delivery, it doesn't slides back and the delivery becomes very easy. So regarding the Blumenthal technique, I'm going to talk more in my next topic. This is a scleral central straight incision, which is about 4 millimeter. Scleral dissection is done. And with the same crescent knife, you take the radial incision. These are radial incision on both the sides. Yeah. So internal incision is bigger than the external incision. And again, there are extension on both the sides, which are called as scleral pockets. Yeah, and now the entry is made with the keratome knife. Enter into the center and do the cutting on both the sides. When you cut the internal incision, the cutting is done when the blade is going from outside to inside. I'll skip this video because I'm going to talk on the Blumenthal technique in the next talk. Now, during the construction of the tunnel, you should be exactly halfway in the sclera so that there is sufficient scleral bed to support the tunnel. If the dissection is very deep, the sclera, the lower part of the sclera is very thin, it cannot support properly, and then you get what is called as scleral disinsertion. So this is not a good construction of the tunnel. If you go very superficially, you can come out very early, and this is called as a scleral buttonholing. So this is a small video of scleral buttonholing. I am dissecting from left to the right side, but suddenly the blade has come superficial and it has come out here, creating a hole in the outer sclera. So what I have done, I go again deep, create another tunnel at a deeper level, keeping the buttonhole at the top level. So this is how I have tackled the buttonhole here. Now I'm just showing passing the repositor. The repositor is now out through the buttonhole. Sorry. Yeah, now the repositor is out through the buttonhole, and second time the repositor is again taken out. Now I am passing it through the deeper tunnel, which is a proper tunnel. If this is not possible, you can straightway abandon the site and start the dissection in some different order, and you can complete the surgery. Now, while doing the construction of the scleral tunnel, if you go suddenly deep, you can have a premature entry. And if you have a premature entry, perhaps this part of the sclera can act as a wall, but there can be a troublesome prolapse of the iris during the surgery, and it becomes surgery can become very difficult at times. Here the blade is quite sharp, and suddenly I have entered here before the limbus only, and a premature entry has taken place. So now in this case, iris is repeatedly coming out. When the nucleus is delivered, again you can see the iris popping out. The ECCE internal also is on. Now I have pushed the iris with the iris repositor, but again during the surgery it keeps coming out. Now while doing the implantation of the lens, now here the lens itself is taking the iris back. At the end of the surgery, you have to check the integrity of the wound in such cases. If there is leakage, you have to put a single stitch. But many times, even in spite of a premature entry, the integrity of the wound is very good and a stitch is not required. And you have to see to it that you have to use sharp instruments for dissection. Otherwise, you can get the detachment of the descemet membrane, and unnecessarily, in spite of a good surgery, the cornea gets fired. Now, because of the ECCE maintainer, the globe becomes pressurized. So if you're not using ECCE maintainer, you can use at least viscoelastics to the side port and make the scleral wall very taut. If the globe is pressurized, the walls become very taut, and the dissection becomes very easy in the layers of the sclera. And consider doing the dissection in a flaccid wall of the sclera. The dissection cannot be a very good one. So always do the dissection in a pressurized globe. And while doing the dissection side to side, always keep the contour of the globe also in the mind, so that you can go into the proper plane. I'll skip this slide. If at all there is leaking in the tunnel, there are multiple ways of suturing the scleral tunnel with multiple sutures or single sutures. So have patience, have perseverance. There is always light at the other end of the tunnel. I'm going to my next talk now.
Yes, sir.
I'll show you. This is a video of, I'll show a single case of Blumenthal's technique of mini nucleus technique, which is done with the ECCE maintainer, and I'll be showing side by side my tips also. Now already the peritomy is done. So when I do the peritomy, I inject the BSS or a local anesthetic under the conjunctiva. The purpose of forming this bleb with the BSS is that whenever you get bleeding in the conjunctiva, the blood cannot enter the space. So this acts as a barrier for the blood. So cosmetically, the eye also looks very good. Again, when you do the dissection of the tenon, once you cut the tenon, again inject the BSS under the tenon also, form a bleb under the tenon. So that also prevents the entry of the blood into the entry chamber, into the subtenon space, and the eye doesn't look that red. Now this is a MVR blade, and I am making a tangential opening near the lower limbus. This opening is for the entry of the anterior chamber maintainer, and on the sides, again I am doing a side port, but please note that initially when I do the side port, I don't enter the blade completely. I'll tell you why it is done so. This is the entry of the anterior chamber maintainer, and the fluid is continuously on, the globe is pressurized. Now I do the dissection directly with the blade without forming an initial groove, The only purpose of doing this method is that cosmetically the wound looks very good post-operatively. Many times you can hardly see that there is only 1 or 2 millimeters of the central grooving, and the peripheral parts become indistinct. So cosmetically this wound looks very good. Straight away I start the dissection with the scleral tunnel. Now this is a front incision, but this front is little more curved because my curvature of my incisions, they depend upon the pre-existing astigmatism. I am doing the scleral pocketing on both the sides. Another advantage of AC maintenance is that even if there is a bleeding into the scleral tunnel, the blood cannot enter the antechamber. At present, the antechamber is not open, but we can see in this video, during the further surgery also, the blood doesn't enter. Now the cornea is also dissected for about 1 millimeter, but the antechamber is not open at this time. Now, I had shown you that I have not made the complete side port here because this is almost half the breadth of the side port. The only advantage is that in Blumenthal technique, we don't use viscoelastic. The antechamber is well formed because of the BSS, and you can do a beautiful capsular exercise as if you are doing under viscoelastic with a cystiptone needle which is passed through a side port, which is not a proper breadth side port. If the side port is complete, there is continuous seepage of the fluid here, and the capsule becomes very capsule keep moving. You cannot do a proper capsular exercise. So this is a capsular exercise done without viscoelastic. I do the surgery under topical anesthesia, and mostly it is done without viscoelastics. Now, once the capsular exercise is completed, now you put the MUR blade again. Now, this is the way I do the capsular exercise. The needle is mounted on the Sinskey hook. This is a Sinskey hook. On the back side of the handle, I mount the needle because here we don't want any fluid in the right hand. So, like a pen, you can move the capsular exercise needle because fluid is continuously coming through the AC maintainer. So once the capsular exercise is completed, again I pass the MUR blade through the same port to make a complete proper bed side port now, through which mostly the capsular exercise also comes out. Heterodissection also is come through the side port only. The main port is used only for nucleus delivery and the IOL implantation. Because even if you do the heterodissection through the side port, there is continuous egress of the fluid here. So it is not risky to do heterodissection through the side port unless it is a very watertight side port. The nucleus is taken into the antechamber. There are different methods of taking the nucleus into the antechamber. It can be single-handed technique, it can be two-handed technique. Now, the nucleus is kept partially prolapsed into the antechamber. It is not totally taken into the antechamber. Some part of the nucleus is kept into the capsule so that when you enter the antechamber with the keratome, the nucleus doesn't rub the cornea and the endothelium also is safe. Now this is a central opening. The keratome is now parallel to the iris, and the cutting is done when the blade is going from outside to inside. Now the internal entry is completed. So you can see that the blood is continuously going out. It is not entering the antechamber. Now I have depressed the posterior lip with a sheets glide. Sheets glide is a thin plastic glide, and the nucleus gets trapped into the scleral tunnel because of the hydrostatic pressure, and the nucleus is slowly delivered out. If it gets totally entangled, you can fragment the nucleus into the scleral tunnel, which is a very safe method of fragmenting. Throughout the surgery, you can see the blood is not entering into the antechamber. Now I am doing the aspiration through the side port again because the AC maintainer is on, which is continuously feeding the irrigation. So this is not a Simcoe cannula, it is only a single port aspiration cannula. So it's a part of the Duet's cannula, only the aspiration part I am using, but that is connected through a tubing to the syringe, which is in my left hand. So one right hand is holding this aspiration cannula on a handle, and the left hand is holding the syringe, which is doing the manual aspiration. But the irrigation is continuously coming through the antechamber maintainer. Now, many times one side port on one side is sufficient, but in some case you find difficulty to suck the cortex on the right side. In that case, sometimes I take a side port on the left side also. You can do the polishing of the entire capsule with the same cannula. Now here you can see that the capsule, posterior capsule has got sucked into the aspiration cannula, but because of the AC maintainer, again I could easily release and the posterior capsule is not ruptured. Here I have taken the left side port entry also. This is mainly for the aspiration of the cortex on the right side, but every time it is not required. So if required, you can have one more side port on the left side. Now, if at all you are doing the capsular polishing with a ring polisher, because of the egress of the fluid, the chamber tries to become shallow. So here I'm holding and just making temporarily the tunnel narrow so that the chamber remains deep. And this is a foldable lens, but if you are putting a rigid lens also, the lower loop should go straight into the capsular bag. Otherwise, it can rub the corneal endothelium, because it is little difficult with the AC maintainer on to insert a lens. So once the lens goes inside, all the manipulations can be done again through the side port, and the lens can be properly placed into the capsular bag. Once the IOL implantation is done, you can see that I have swiped the repositor again through the main port, because many times small particle matters get stuck in the sterile tunnel. If we just swipe the repositor through the tunnel, everything gets washed out. I just measure the incision at this end. This is about slightly more than 5.5mm incision. Many times I am operating through a 4mm incision also. Now the hydration of the side ports also is very essential step, because at this stage suddenly you can detach the descemet membrane. So you have to be very careful. And the AC maintainer is the last thing to come out and hydrate this last port also. And this is almost the end of the surgery. You can give the subconjunctival injection of steroid at any place. Many times I give it in the superior conjunctiva only to form a nice blade. And in that case, sometimes cauterization is not required. Thank you very much. I should end here, and thank you very much.
Thank you, Dr. Blumenthal, for this wonderful presentation, and well done cases and videos. Also, I'm thanking you too much for this great innovation in the field of small incision. Even we can do the manual small incision surgery now under topical anesthesia and the visculus with the ACB to help keeping the space inside the eye and help pushing the nucleus outside by the fluid. No need for the viscoelastic, and still keeping the corneal as sound as possible. Thank you, sir. And because of the sake of time, because Dr. Carla Pamela, have another meeting on the other side, so I may ask her now to start her presentation. Hi, Carla. Okay, start, sir.
Hey, Dr. Hossam. Thank you very much, Dr. Baramani. That was an excellent talk.
Thank you, madam.
So can you see my screen now?
Yes, I can see your screen now, and you will conduct a presentation about how you are, as a phaco surgeon, shifting to the manual small incision for all of us.
Yes, of course. So this is a presentation where I want to share why am I interested in MSICS if I am a phaco surgeon. So first of all, thanks everybody. A special thanks to Professor Hossam for the invitation, for the Egypt chapter of ISMSICS, and for the Egypt Ophthalmological Society. And Dr. Sahu, it's very nice to have you here with us. So thank you all for the invitation. I have no financial interest, and well, why, if I'm a phaco surgeon, I'm interested in MSICS. So what we have traditionally heard, phaco is the gold standard for cataract surgery. MSICS is a really good alternative in developing countries. It's a low-cost surgery. So that is what we have traditionally heard. But I would like to see it in another way. So let me share it with you. Who said it was a competition? I don't know if in your country, in Egypt, I'm sure not in India, but here in Mexico, a lot of people are fighting. Which technique is better? Is phaco better than MSICS? Is MSICS better than phaco? But who said it was a competition? I'm really convinced right now there's room for both of techniques. There's room for phaco, there's room for MSICS. And for us as cataract surgeon, it's really important to master both techniques. So who said, as a cataract surgeon, I have to choose between one or the other technique? So just for fun, let's imagine we are in a beautiful afternoon. Well, imagine for myself and the people in India, not for you. I'm sure you're having a beautiful afternoon in Cairo. So let's imagine we're having a beautiful afternoon there with all of you. And let's set the table for dinner. It's dinner time right now there, so let's start the table talk. So what's in the menu for today? So for starters, we have a breathing paradigm statements. For a main course, I'm gonna tell you a little bit about my experience with MSICS. And for dessert, I wanna share with you what I have learned from MSICS in these years. So a breaking paradigm statement for starter. MSICS, ideal for developing countries, an alternative for really hard cataracts, low-cost surgery. Yes, this is all true. This is what we have heard about MSICS all the time. Ideal for developing countries, of course, because not everywhere, not in my country, patients can access a phaco surgery. So we have to offer them a very good technique, safe technique with excellent results. An alternative for really hard cataracts, this is what I have learned with the years. A good phaco surgeon will tell you, I can take every cataract out with phaco. I don't need MSICS. The thing is, we have to think about the endothelium. We have to think about the sonula. We have to think about inflammation next day. So MSICS become a really, really good choice in really hard cataracts. Low-cost surgery, yes, that is a concern in my country because there are not enough resources to offer a phaco surgery for everybody. So we do have to have trained surgeons in low-cost techniques where we can offer our patients excellent results with the same amount of safe and confident as a good technique as a phaco. So the main course, I'm gonna tell you about a couple of cases in my personal experience where MSICS actually rescued my phaco surgery. So I have to make a confession. A few years ago, I was not an MSICS believer. So I have become now an MSICS believer. So the situations I choose to share with you are these two cases I had last year. The first case is a 50-year-old male with previous radial keratotomy. And as you can see, he has a high myopia in his right eye. Not only because of previous radial keratotomy, but also because there was a cataract there which was blocking his vision. So that was his main concern in the consultation. So let me share with you the video. The video has stereo, so I hope you can hear it.
MSICS rescuing a phaco surgery. We present a case of a 58-year-old man with history of radial keratotomy, 16 cuts. He complained about blurry vision in his right eye. The right eye uncorrected visual acuity was 2400. He had a cataract in his right eye, so we decided to make a phaco surgery. We started the surgery making an accessory port between the incisions. Afterwards, we decided to make a scleral tunnel. After a gentle hydrodissection, we sculpted a groove and divided the nucleus into fragments. We were about to start the shopping when we realized one of the corneal cuts opened and started leaking. After thinking a few seconds, we decided to convert the procedure to MSICS, since the cornea had too many and deep cuts. We sutured the cornea and afterward started the scleral groove. The nucleus was already divided, so we needed a small scleral incision. We luxated the fragments to the anterior chamber and took them out with a hook. Afterwards, we cleaned up cortex with a simple cannula. Since we already had a continuous circular capsular rhexis and a one-piece foldable IOL, we decided to continue with the original plan and put the IOL in the bag. We had a self-sealing corneal incision, so we did not have to suture the sclera. The result next day was really good. Uncorrected visual acuity was 20/70. Uncorrected visual acuity was 20/40. This case is a good example of how MSICS can rescue a phaco surgery and still get excellent results.
Okay, so let me show you the second case. So for my second case, it was a regular day at the OR Cataract at DIMO, which is the institution where I work. And suddenly one of the anterior segment fellows asked for me in the retina OR. So when someone asks for you in the OR, it's because something is maybe not going that good. So what happened? He made his best face and started saying, it was a really hard cataract. Patient is scheduled for phaco and silicone oil exchange. Everything was going well and smooth with phaco, but there's always a but. When there's a but, it means there's complications. I had a wrist prolapse during the whole surgery, and when I put the IOL in the bag, I realized the IOL was broken. So let me show you the video of what happened. You always have to take a deep breath before trying to solve a complication and think very good of what you're gonna do. So this is the video. The video doesn't has no audio, so I'll start telling you. So this is where my fellow was doing the hard cataract. You can see the silicone reflect in the bag. So there you can see the IOL has a big tear. So that's when he asked for me. So I went in, I saw we have an IOL in the bag, and what first came into my mind was to cut it and get it out through the corneal wood. But I had a lot of posterior pressure because of the silicone oil. So I make 1, 2, 3 attempts. The iris was prolapsing as he told me through the wound. So after 3 attempts, I decided not to move anymore that wood, and I decided to make a scleral tunnel. It didn't have to be a big scleral tunnel because it was a foldable IOL. So I just needed a way to go inside the anterior chamber, grasp the IOL, and get it outside without having the iris coming through the wound. So as you can see, it's not a big tunnel, it's a small tunnel. I just took the IOL outside and then replaced it with a 3-piece IOL. We had a continuous circular capsulotomy, so I could put a 1-piece or 3-piece IOL, whatever was available for that time. So I just finished the case. In this case, I put a suture in the groove because they were going to perform the silicone oil exchange afterwards, so there was going to be a lot of pressure in the eye. So that's why I decided to put a suture there. So for dessert, what I have learned about MSICS through these years. Dr. Sahu kindly told me a few years ago, if you learn a different surgical technique, you will be a more complete surgeon. So what I said at the beginning, I hold it right now. I'm not saying which technique is better. Both techniques have shown their efficiency and safety rates. What are we doing right now? Well, hard cases, special cases. We know some cases where MSICS is really gonna benefit us, and we're also moving on and putting premium IOL in MSICS patients who do not have the money to pay for phaco and premium IOL, but we're trying them, well, let's give them the benefits of the premium IOL with a surgery that isn't that expensive as phaco. For everybody which is in this webinar, we have an online free course for MSICS at this website. We will be glad if you can join it. And don't forget the takeaway. Learn a surgical technique as effective as MSICS will give you, as a cataract surgeon, more tools for you to face complicated cases. Thank you very much. Thank you, Dr. Hassam, and I hope this presentation was useful.
Thank you, Dr. Carla, for this great jobs and wonderful videos and presentation, especially the idea of getting the silicone IL from the wound of the scleral tunnel after trying with the phaco first. All the time, when you manage with the distance, you can control. It's much better than managing while you are inside or very close to the field itself. Thank you very much for your participation and your great videos. A brave lady and a good, brilliant teacher and trainer in the cataract surgery. I know you don't have a time, so I will ask you one question before leaving. You said at the start that it is not manual small incision cataract surgery is not for not for the developing countries, but also in the other parts of the world. In Mexico, you are doing that and training your surgeons for the manual small incision cataract surgery. Also in Boston now, Bonnie Henderson starting the work about the small incision in Boston, in America. You see that it's a very good and safe alternative in cataract negra in such cases than the phaco procedure, even the surgeon can do. You think so in all cases?
Yeah, I think it's a good alternative in all cases. As I said at the beginning, maybe in the past, or at least here in Mexico, that was how the idea of manual small incision cataract surgery was brought to us. It is only for developing countries. It is only for really hard cataracts, but it is not. The procedure itself, the technique itself, has shown its safety and its efficiency. So it could be done in any cataract, in any environment, by any trained surgeon, and have excellent results.
Usually you bought a premium IOL in such cases too.
Yes, of course. So it's your decision as a surgeon what to offer your patient for having the best result.
Okay, it's not just for the far areas, the poor areas, and not for the desert areas, not for the campaigns in the far Africa, and so it's also suitable for your cases in the civilized countries and cities. You can do it instead of the phaco emulsification to save the cornea and to save yourself first from the stress which can you get when you're stuck in such a cataract nigra and dense brown case, especially with a bad cornea. You will be worried about the endothelium and the thermal effect on it.
Yes, of course. It gives you a really sense of security when you have a really bad cornea, when you have a weak cannula, when you have a really hard cataract. Well, I'll just take it out by the manual procedure, by MSICS, and I won't have the stress with phaco, and I know the patient is going to be great the next day. So yes, as a surgeon, it gives you a really powerful tool to manage tough cases.
Yeah, actually, it's my strategy now, not just for being the president, the Egypt chapter of the International Society of the Manual Small Incision Cataract Surgeon. I'm not just a fan for the manual small incision, but also I'm doing it in my practice. I have a series of cases of dense brown and cataract nigra. I have done one eye with a phaco, and I could do it. And the other eye with a manual small incision cataract by the manual small incision cataract surgery or this technique, I saved the time, the effort, and the cornea was crystal clear at the second morning or the first morning after surgery. While the other eye, even with all precautions with the visco material cooling all the time, there is some sort of corneal inflammation or of corneal edema, and there is spasm and photophobia for 2 days or 3 days after if I skipped the corneal decompensation. So we are sitting for this strategy today for the old surgeons trying to keep learning and to get the manual small incision technique. Thank you very much. And I know you are busy. You have the time.
Dr. Sam, I'd like to add something, please.
Yeah, okay.
Dr. Bamila, I'd like to thank you for this nice presentation. But I want to add something. I can get benefit from steps of manual small incision cataract surgery, especially the incision in small incision cataract surgery in phaco cases, especially if there is complication like tear in the posterior capsule and there is no capsular support for implantation of any IOL. I can get benefit from the incision for implantation of retropupillary iris glue. I got this from your presentation now. Especially if there is no support, I'd like to make a frown incision and implant retropupillary iris glue without need for any sutures and avoiding any astigmatism, and the patient will get benefit from this procedure like this.
Yes, of course. As you said, whenever there's a complication in the phaco, sometimes and most of the time you will get a great result and be benefit from converting your surgery to an MSICS. So yes, totally agree.
Okay, thank you, Dr. Pamela, and it was very good to see you and to participate with us. And if you want to leave now because your time, okay.
Thank you. So sorry thank you for the invitation.
Okay, thank you for your participation. Thank you, and see you again. Bye bye. Bye bye. For other speakers, please, we will check. We will collect the questions at the end, because Pamela will leave now for other webinar. So we will complete the next presentation, and then we will end it by my presentation, and then start discussion at the end. So I may ask Dr. Rakesh Shakia to share his screen now. Dr. Rakesh, are you here? Rakesh, I will unmute you now.
Yeah.
Rakesh?
Am I audible, sir?
No, now, yeah, you're
Yeah.
okay. Dr. Rakesh Shakia will present a different difficulties and how he had managed them in manual small incision cataract surgery, and then we'll end his presentation with the fruitful video with the small incision cataract surgery in just 2 minutes. And
Thank you.
the fastest.
Thank you for the comment. And
Small incision.
hello, am I audible? I'm sharing the screen.
Start
I'm
sharing.
sharing the screen.
Start sharing, please.
Just
Yes, Rakesh?
yes, I'm just sharing the screen.
Yeah, but I cannot see your screen now.
Yeah, just sharing the screen.
Yes.
That's okay.
Okay, now I can see your screen now. Please start.
Am I audible?
Yes.
Yeah. So I'm very thankful to Dr. Sher and especially the Amul Sahu sir and Boramani sir to actually to give the chance here. I'm not a very good speaker, but I'm trying. So the small incision surgery is a very good surgery, and they are the both phaco and as well as the SICS. Both are give the best good results. So there are the many situations like small pupil, hard cataract, and pseudo exfoliation, and they are the hypermeasure cataract. But in the few minutes we actually completed the few situations. So we can do the M6 can be doing the all types of the cataract surgery. So this is the case of actually the small people with a hard cataract, and the people is slightly the hard. So we make a small incision is about the 6.5 mm and make a side pocket in this case is very important, and then enter in the keratome and then cut it. So this is the small people. So I use this sphincterotomy technique in this case with the help of the Warner seizure, and then make a try to put rexis under the iris. You can go just outside when you hold the tag, and then go outside and in, and make a adequate size of the rexis. And now we do the slight multiple hydrodissection, and then see the just forward movement of the nucleus and collapse the one pole of the nucleus, and then push the visco behind it and over it, and then rotate the nucleus in the opposite direction. So this is the very big nucleus, and so we put the visco on the side and over the nucleus, and just create the space uh, behind the nucleus, and then with the help of the irrigating vectors, and just remove it. But unfortunately, I actually noted the fibrous posterior capsule. So I actually do the this capsule by cut by the protector and make it circular. This because it can hamper the vision. So this was a very thick capsule, so it is not cut by the India glazer. So and then put the 3-piece oil in the sulcus, and the pupil is become mostly circular. And then this is the another case of pseudo exfoliation with hard cataract. So in this case, I always follow the two-side port actually, because this is a all small pupil, and also make a very slightly larger tunnel in the 6.5 mm, and then you can see the crescent. easily go in the both sides and make a tunnel on the same way. And then as you actually Dr. Boramani also said, the side pocket is very important to deliver the very hard nucleus. So with the side pockets, so we just stage the pupils, make it slightly bigger and flexible and make it, but the pupil is slightly low, so we can use the Coughlin hook to actually retract the particular area and make a axis very easily with the help of the Trata forceps. You can retract the iris with the help of Coughlin and the particular area, and then you can make an axis very adequate size of the axis. So this technique I always actually teach my fellow. And then multiple hydrodissection, try to collapse the bun pole first, and then put the bisco behind it, and then rotate the nucleus in the first one direction, and then this is also very big nucleus. And put the bisco over it and just corner and with the help of the wire vectors deliver it very easily. And for the cortical removal is very important because the in the pseudo exfoliation there the chance of the joint dial is slightly higher. So go just retract the iris and then remove the cortex and then put the eye in the bag. So after the implantation, this the hook can be actually to identify the eye is in the bag or not. So you can just retract the iris. You can see the capsular margin very easily. And we can see the eye in the bag. And this is the another case is the complicated cataracts and the membrane is slightly thicker. So we can't peel up with the help of the Trata forceps. So by this reason, we actually cut it with the help of the one incision and make the pupil slightly, try to make a pupil slightly circular. But the pupil is slightly bigger or small. So by this reason, I decide to do 4 port. And then with the help of the iris hook, we retract the and make a pupil slightly dilated and then make our axis very easy. And then remove the cortex, and after that we do the after the removal of this capsule, and then we put the IL implantation. This is another case actually. This is a phacolytic glaucoma, and then before the cataract, so we aspirate this cortex material first, and then stain it, and then we assess the nucleus size and the jonular laxity. And after making the tunnel, it is slightly with 6.5 mm, and then so in this case, actually the capsule is very fragile. So actually with the help of the cystitome, you can just puncture it and then remove some amount of the cortex and then gently actually do the axis. If you feel any resistance, you put the visco again and then stitch and then make it circular. When the axis is not proper, then you can use the one scissor to cut it. So nucleus always in this type of case slippery, so put the visco and rotate it by the rotational movement, and then you can deliver the same way. So actually there are the many complicated situations. Actually Dr. Hossain give me the only 5 minutes. So I just completed finished this
okay, you
presentation.
can have this free 5 minutes.
Thank you.
Okay.
Thank you very much.
Thank you, Dr. Rakesh.
Yeah.
Okay. Where is the video you told me about, the record of time?
Yeah.
You said you will show a video of just 2 minutes. 2 minutes.
Yeah, we have the another presentation actually.
Now?
If I continue.
Yeah, okay. Go ahead.
Yeah, just a minute.
Dr. Rakesh is the fastest surgeon I have ever seen in the world. For he can do the small incision cataract surgery, all of it, in just 2 minutes. And I have seen his live work in the live surgery in one of the International Society of Small Incision Cataract meeting in Kolkata. He showed live surgery of small incision cataract surgery in just 3 minutes. And so we will forgive him for the extra minute for the live surgery itself.
Yeah.
Okay, share your screen now.
Yeah. Am I audible? Yeah.
Yeah.
Thank you. So, as you all know, this the M6 is not a bad surgery. It is a surgery for the all country, not for the developing country. Oh, sorry. So, why the M6 is needed? This is the one wonders we each have both of them. So in the developed country, that the large population, they are the unmet need of the cataract surgery. In the India, actually, they are the 9.12 million people are blind, and 50 to 80% due to the cataracts. So the blind people added 3.85 million due to the cataracts. So this is the small incision cataract surgery in the 2 minutes. So initially, I just make a side coat and with the at the 8 o'clock, and then put the visco. This is the immature cataract. And then initially make a peritomy after the tighten the radial suture and make a front side incision is about the 6 mm. At the 5.5 mm, 6 mm it is proper for the all type of the cataract surgery. And then AC entry done by the keratome. And with the help of the Trata forceps, we make a rhexis. And the hydrodistraction. This is the nucleus slightly hard, so flap the nucleus and rotate with the help of the hydrocannula and the flap the nucleus in the antechamber. Legal notch is very big, so we can, with the help of the Ricket waxes, remove it very easily. So after that, I always implant the oil in the saline. Just keep the Simcoe cannula in the side port and then make the chamber deep and then dial with the help of the Simcoe. You can see the bag and then hydrate it and put the intercameral moxie and then always. So how to develop this technique in the 2 minutes? So they during the all surgeons follow the same protocol. So why this reason? We develop the technique like when the fellow is come to the R Institute. So they follow actually just teach the same technique to all fellow. So why this reason? After the 1 year, the fellows become the confident, and some surgeon doing the cataract surgery in the 3 minutes and 4 minutes and 5 minutes, not more than that. So we can divide the cases into the 3 parts. Actually, when the simple cases done by the juniors and the complicated done by the senior. So the 70% cases can be done very easily in the very limited time, and the other cases were done by the senior. So so this surgery, because the actually I am doing the high volume center, because in the one day we can do the more than 800 cataract surgery per day. In the last year we done about more than 1 lakh surgery in a financial year. So we do the 80% of the cataract surgery, the small incision cataract surgery here, and the 20% only the phaco. But this is the surgery before the COVID era, because now the many guidelines are actually nowadays actually I believe. So why this region? So with surgical time becomes slightly increased, but the surgery in between the two surgery the slightly increased because there the cleaning and other thing is actually take the time. So the surgery also complete in the less than 2 minutes. I always put the steroid injection after that and report this conjunctiva. So during the training period, every surgeon follow the same protocol. Gradually with the time, surgeon become confident. We did the approximately 800 per day. So this is the M6 in 2 minutes. Thank you very much.
Thank you, Dr. Akishakia, for this
Yeah.
great presentation and the great work. It's very nice. It's very good and encouraging to do the surgery in very short time and still keeping the all steps well performed and still keeping the eye safe. But actually, let me to say that the time. The time saving is very important point, but actually the eye safety is the most important point here.
Yeah.
In all surgeries, but it's encouraging for the all surgeons to optimize the work and lessen the time, because the less time surgery will keep the time, will keep the effort, will keep the staff, and also will keep the eye from the complications of the long time surgery. Thank you very much for your wonderful participation in videos. And then let me to go for my presentation.
Yeah, thank you.
Thank you very much. I will share my screen now. I'm Hosam Ziada, Assistant Professor of Ophthalmology at Azhar University, and I will talk today about the stepping from the cataract surgery, the extracapsular cataract surgery to the small incision cataract surgery. And I'm talking as a responsible person about this activity because I got the honor of being the president of the Egypt chapter of the International Society of the Manual Small Incision Cataract Surgery, hoping to conduct a lot of activities and programs for this technique today. So can you see my screen?
No.
Yeah, we can see.
Yeah.
We can see the banner, yeah.
Yeah, you can see my screen now, right?
Yes, yes.
And can hear me.
Yeah, very well.
So my talk title is From the Laced Suture to Sutureless Non-Phaco Surgery. The first step to do it, in my opinion, to start with the your extracapsular surgery steps, to do most of the manual small incision steps during this procedure first. It's not easy to shift abruptly or from a technique to another technique. You have to take it in a stepping and to optimize the step first in one technique and then go to the next one. So I have started this, and I'm still keeping all of that today in my own practice to do the extracapsular surgery, but in a modern way, in the different way. When I start teaching our residents in the university, I'm telling them you have to start it from the classic scratch. You have to do classically the extracapsular cataract surgery and then go to the next technique, whether small incision or also the phaco emulsification. You have to optimize this first, to master all the steps first before going to the next. Otherwise, you will lose the technique. Most of the surgeons now, especially the new generation of the juniors now, are hurried to do the phaco emulsification before mastering the old steps and the old difficult scenarios and situations of the extracapsular cataract surgery. And in my opinion, they are gaining a phaco emulsification and losing at the same time the basic techniques, which is these basic techniques are all the time so significant for their work, because the surgeon which jump directly to the phaco emulsification without mastering the basic techniques, he will, when he got any complication, he will be like the person who is falling on the ground without stairs. So it's very, very important for the all to keep optimizing the extra cap, the manual small incision, beside the phaco emulsification. So I started in these cases to do my extracapsular cataract surgery in the modern way. How to be in the modern way? To do it with the limbal incision, small limbal incision, or even the classic incision, which is 10 millimeter wide of the extracapsular, but keeping them with the least stitch and doing the all steps needed for the small incision in this technique as well, which is the rhexis, the caps rhexis, which is wide enough to deliver the nucleus in the anterior chamber and then deliver the nucleus in a different way, and then keep doing the lamellar incision. I'm keeping the time to do a lamellar incision in the posterior limbus because this will help coaptation of the bone with the least stitch, which I place at the end of the surgery. As you see now, the nucleus is coming out very easily. Then I prefer to remove the speculum in such step because I didn't put stitches at after delivery of the nucleus. I'm keeping the stitches even in the extracapsular surgery for the end of the surgery. Then I pushed the cortex and the epinuclear segments away by the viscera and implanted the IL. And keeping now, I'm putting the IL and rotating it inside the back. Because there is no speculum, there is no pressure, so the vitreous is calmed down posteriorly in its place. There is no danger, and there is no bulging the posterior capsule during my technique, so I was not scared. I'm doing hydro dissection, the Miller dissection at both ends of the bone. Then I will put, because the bone here is 10 millimeter wide, I put here a figure 8 stitch, which is like two close stitches together. And at, this figure 8 stitch was so enough in such case to keep it safe, and watertight wound with no leakage or no iris prolapse at the following days after surgery. So I'm doing now the figure 8 stitch. And if you notice, there's no iris prolapse during placing stitches. Even I invert the corneal side of the wound, or the corneal lip of the wound. So everything is okay, and I was comfortable with this technique. But keep in your mind to remove the speculum to relieve the pressure. There is no back pressure or twisting pressure by the speculum on the glue during this moment. Then I will put my speculum again to widen the palpebral fissure and complete my steps. I will remove the old cortical matter and the epinuclear fragments in the anterior chamber by the double-way irrigation cannula and Simcoe. And so if you don't have any tools of the phaco device or the bimanual irrigation aspiration, you can do it by the simplest instrument. Then I will check the bone coaptation again and the iris regularity, and then we will inject the air bubble from the end of the wound. And it's well formed anterior chamber. Even after removal of the speculum, there is no escape or prolapse of the air bubble, and everything was okay, intraoperatively and postoperatively as well. Another case in which I will show how I decreased the width of the wound and decreased the number of stitches. Also, I'm doing now the capsulorhexis without stain. It's a challenge I liked to put myself in front of it. And then I deliver the nucleus in the anterior chamber by the flipping of the nucleus using the hydrodissection. Then I will inject the viscoelastic all around the nucleus, and then above the nucleus to keep it away from the corneal endothelium. And then I will increase the width of the corneal wound to be just 8 millimeter, not 10 in this time. And because the nucleus diameter is more than this wound size, I will use the sandwich technique to help pushing the nucleus out. It's 8 millimeter, it's measured by the caliper. And I can call this technique the corneal manual small incision, not scleral, but corneal. Very easily, I deliver the nucleus by the sandwich technique, by the scope below and Sinesky above. It's called the sandwich technique. I'm doing now the expression of the epinucleus and nuclear matters, the cortical matters by the hydration of body fluid. It's so easily, there is no problem with the posterior capsule, with the inside tissues of the eye. Then I'm implanting the IOL now, but please notice how I implant the upper haptic. I'm catching it and twisting it by rotating it up to twist the shoulder to be inside the bag, and then leave the haptic to be both haptics inside the bag. It's hard IOL, less costly, but inside the bag too. It's not in the sulcus. Then I placed just one stitch. It's extra capsular surgery with just one stitch. You can remove it after 2 weeks with no astigmatic, residual astigmatic effect after that. The anterior chamber is stable. There is no iris problems. There is no iris prolapse, and the pupil is rounded and regular. And I will complete the irrigation aspiration from the side pores here to keep it closed system, like in phaco. I performed, or I fashioned this side port by the keratome, or even by the MVR if you have, and then completed my irrigation aspiration, keeping the system closed, hydro section of the old side pores and the mean wound, and then injected the air bubble at the end to keep the anterior segment, or keep the anterior chamber closed and well formed. And I checked at the end the coaptability or coaptation of the wound by pressing on the air bubble. If there is leakage or the wound, if the wound is leaky, the air bubble will get out. Let's go to the second step, which is the sutureless scleral tunnel. Then I moved from the 3 or 4 stitches in extra cap to figure of 8, and then 1 stitch, and then going to now the sutureless scleral tunnel small incision cataract surgery. And this is one of my cases. It's cataract nigra, which is the hardest cataract you may face in your life. And this patient, I have done the other eye with the phaco emulsification, but this eye was done by this technique. I'm going now to do the rexes after staining, because it's black. There is no red reflex. And at the same time, it's not wide to take the moving line of the rexes. So I'm doing it from the side port by using the cystotome. One of the options, so you can do during the manual small incision cataract surgery, to do the rexes from the side port before before making your scleral tunnel to keep it closed. Then my scleral tunnel, I used to make the scleral incision of 6 millimeter width and 2 millimeter at least away from the limbus. Then I'm doing now I'm creating now the tunnel using a good and new pressure knife. Then I started at the center, then moving right and left. And then when I finished this scleral part, I enter in a wider fashion to the interior of the eye. Then by the keratome, open the cornea, the interior part of the cornea, and then increase completing my rhexis very easily. And I tend to do it as a big and wide rhexis to allow easier delivery of the nucleus. Now by the hydrodissection, I will deliver the nucleus chamber, then completed delivery by the application of the nucleus using the Sansky dialer to bring it in the anterior chamber, then inject visco material after increasing the internal part of the inside of the wound. Actually, the internal side is larger than the external part of the external side of the wound. It's 6 externally and around 8.5 internally. Then it is the sandwich technique again. It's like cataract. Then removing the epinucleus, the cortical matter, first from the scleral tunnel itself, and then completing removing of the thinner flaps and the peripheral part from the side port to keep it closed. Finally, I'm implanting the IOL by the same technique, hard PMMA 6.5 millimeter IOL. Then I twist the shoulder by rotating the upper haptic up and then putting both of them inside the back. Then the final wash, the hydrodissection. And like I'm doing now, the stromal hydration of the internal sides of the corneal part of the wound, like the external part, then my lovely air bubble at the end, and coaptation of the conjunctival sides together by the cautery. I'm always closing my wounds by the cauterization of the scleral tunnels, by the conjunctival sides together. And thank you very much. And this photo with the Professor Amalio, the founder and chairman of the International Society, and on the other side there is the Mexican colleagues, Dr. Barla, Carla, and one of the other professors in the Mexican Institute. And this is the medal which I had the honor of getting the gold medal from the International Society of the Medicine. And thank you for your attention. And I may ask Dr. Amr, I think you have questions now?
Yeah.
I think you have a question for Dr. Ahmed. You told me about that. Please.
Assalamu alaikum.
Assalam wa rahmatullah.
Dr. Ahmed, a nice presentation. I'd like to ask Dr. Ahmed for envelope technique for capsular rhexis. In cases of intumescent cataract, how can I perform this technique? You mentioned that I can do envelope technique in cases of narrow pupil, but in cases of intumescent cataract, I think it will cause an extension easily in this case. Yeah.
Dr. Ahmed Mustafa? Dr. Ahmed Mustafa? Dr. Ahmed, oh, unmuted. Sorry, you are muted. I will unmute. Dr. Ahmed?
Okay.
Okay, sir, you are unmuted now. You can answer the question of Dr. Amradi.
Dr. Ram, just for as you see in the video, but I didn't complete all the video till the end, just to have the either brown cataract or intermittent cataract or cataract, just to use the same, use the needle as a super just clean cut from the nasal temporal side in the anterior capsule in the junction between the upper fourth and lower three fourths. So that it will be easier. It shows just you can deliver the nucleus from this incision, as you can see in the presentation.
But in case of narrow pupil, I think it is difficult for me to suspect that this case may be intermittent or non-intermittent, especially if the pupil is narrow and not well dilated properly during the initial examination before surgery.
You ask now for the intermittent cataract or for the narrow pupil?
Narrow, you mentioned that in case of narrow pupil, I can perform envelope technique during capsular access.
Yes, the same technique. Just you have to, for vasodilatation of the pupil, and you have to use your needle just in the upper part of the lens. So that you have this envelope, and you can deliver the nucleus from this incision. And then you can IA and intrabagal, and then insert the IOL.
Okay, but what about the rectus in the narrow pupil without using any of iris screws?
If it is not available in any pupil dilator, either iris hook or so I tried many cases in such case just to have this envelope technique with no problems, and I have my IOL intrabagal, and I can do the complete the capsulotomy with no problem.
Okay, sir. I can ask this question in another way. If you have this narrow pupil, Dr. Rakesh Shakya showed us a lot of cases with narrow pupil. What about the small incision? You have a narrow pupil. Can you do it on can opener or capsulotomy, or you have to do a rex? Rakesh?
Yeah. Hello. Am I audible? Yeah. I always do this curvilinear capsular access. I'm not actually doing the Kenport technique in any cases. And sometimes the axis is extended. Then we can use the Vanna seizure on the another side, and you can regulate the axis. Sometimes the axis go and the intermittent catalyzed axis go in the one side. So we can make an incision with the help of the cystinoom on the other side, and then make it circular on the other direction. So I did not actually follow the can opener technique in any case.
Okay, but if you stuck with the extended rectus under narrow pupil, I think you may complete this part of extension as a capsulotomy.
If the pupil is undilated, you can just retract the iris with the help of the Coughlin soap or dilator, and we then see where the extension. It is beyond the equator or it is the near to the equator. When it is beyond the equator, you can make the incision, another incision with the help of cystinoom. This is the can opener. Then you can regulate the other side of the axis. This is the technique.
Dr. Ramani?
Yes.
Yeah, the same question, please, about the narrow pupil with the manual small incision. If you stuck with the difficult praxis and you lost part of it, you will complete as a small incision, as a scleral manual?
Yeah, no, my answer will be same as Dr. Rakesh has replied. He has shown beautifully how to retract the iris with Coughlin hook. So either use Coughlin hook or a by hook, retract the iris where you are dealing with the capsule, see the extension, and tackle accordingly. He has perfectly answered the question. One more point I want to make here is that small pupil is not a big problem for an SICS surgeon as compared to phaco, because in phaco you require a good dilatation for visualization of the complete nucleus when you are doing the phaco emulsification. But in small incision, it will not be a big problem. On the contrary, the nucleus itself acts as a pupillary expander when nucleus is taken out from the pupil. So it is not a big issue for SICS surgeon as compared to phaco surgeon. That is another point I want to add it.
Yeah, okay, thank you very much. Yeah. Dr. Ahmed, please, I want to know from your experience about this capsular surgery, if what's the time, what's the exact time you can say that the extension wouldn't be solved, wouldn't be corrected? What's the point of the extension when the extending capsule reaches some point, you will say that I have to change, I have to convert.
In a case of phaco,
Yeah.
you mean, or
In a case of phaco, or yeah, what's the time to change it to be capsulotomy, not rhexis?
in such case, able to plan for phaco, and you have
In other way, what's the dangerous moment you will avoid pulling of the extending capsule?
if you cannot see the extension,
Yeah.
so I will be run under the iris, so I have to stop and I try from the other side.
Yes.
You mean this, or ask for another one?
Yeah. Okay. You will stop and start another path from the opposite side, and
Yeah.
reach
From
it
opposite side.
opposite side. Okay. But you don't advise the beginners. They have an extension and they're not seen. They cannot see the edge of the extension. You advise them don't to pull on it, because they may go to the equator of the lens and go back. Right?
Yes, yes.
Okay. For the other speakers, did you have or did you do a manual small incision cataract surgery on the capsulotomy, or the all cases with rhexis? Starting with Professor Amolia.
Yeah.
Yeah.
See, for the beginner, let us not bind them with this rhexis. See, whenever they have a lot of fears, lot of things, so let them, the rhexis is, let us not put more stress on the rhexis part of it for the time being. Because first thing is that if they are finding it difficult, let them convert it to can opener, so there is no problem. Because if you tell them that you complete the rhexis and bind them, it will be difficult for them. So
Okay.
it is better they give the confidence, and then once you are a master, then you play with your medium. But before that, they must have a easy way out. So can opener is okay. So they should focus on the wound construction. That is the major part of SICS. But let us not restrict them on rhexis. See, what Rakesh is doing with a huge experience, Boramani, these people are masters, so they can do anything. But beginners, they let them have a easy access, easy out.
Yeah.
I will go with that.
Okay. Your advice not to do, especially if you are a beginner, not to do capsulotomy, because in my opinion, I think the risk will be during rotation of the nucleus. If you try to rotate the nucleus and deliver it, you will pay, or you will yield some pressure on the capsule, which may extend, and you will, in such a case, you will lose the nucleus, will go back. And this actually happened with one of the beginners here. Actually, I have done on the capsulotomy in such cases, but after time with experience. But with one of the beginners, we got dropped the nucleus with the capsulotomy, because there's no intact capsule or rhexis to save the nucleus from dropping during rotation and delivery. Okay, and I think you agree, Dr. Brahmani, about that.
Yeah, I agree. But see, everyone should try to make a CCC, continuous curvature capsulotomy. But if you are not making, you can start attempting that, and then if it is not possible, always you can do the can opener or other types of capsulotomies, isn't it? Second thing, this is another advantage of SICS, that is capsulotomy, continuous CCC is not a must for SICS, while for a phaco it is a must. So this is another advantage of SICS. Start doing CCC. If you're not able to complete the CCC, you can always convert to a can opener. And as Dr. Sahu also said, that beginners need not bother much about this capsulotomy business, whatever he is comfortable with. Because when I was a beginner for CCC also not very easy to run for a beginner. It takes almost 25-50 cases, then you develop the trick of it. And here I want to add one more point. When the capsule start extending to the periphery. Now why it extend to the periphery? This is because of the extensive stress on the capsule, because the zonals are pulling the capsule, and there is a continuous centrifugal force. Because of that, the capsule suddenly runs peripherally, because you are not acting on a plane surface, it is a curved surface, plus there is a continuous centrifugal force. Now once the capsule goes to the periphery, multiple methods of bringing it inside have been advocated, or how to convert two different types of capsulotomy advocated. But here I want to give one tip. When the capsule goes to the periphery, in that meridian, you pressurize the globe, put a pressure on the globe in the zonular region by any hook, like lens hook or any instrument, pressurize. Once you pressurize it, the zonals become very lax there, and this centrifugal force is negated. And many times it is very simple to bring the capsular, the leading edge again into the center, because you are now cancelling the centrifugal force simply by pressurizing the globe, just causing a dimple on the globe in the region of the zonals. This is one more simple trick wherein the capsulotomy, which is going periphery, can be easily brought inside again.
Okay.
Yes, sir, I agree with, sir. I agree with. Yeah. Actually, in the cases of the intumescent cataract, sometimes the access go beyond. So you can just pressurize. Then you can just retrieve the access very easily.
Correct.
Okay.
Sir, I have one question for the Varamani, sir.
Yes.
So what are the precaution or step will take during the incision, so we can prevent the wound leak or iridodialysis things like?
Yeah, one thing is that always use a sharp blades, because dissection becomes very easy. But what happens if you are done? We always say sharp blade, new blade per case. But maybe in India, especially the charitable institutes I have seen, they are using one blade for at least 4 or 5 cases. So after doing 4th or 5th case, suddenly if a new blade is given, you cannot imagine the force in your hand, and presuming that it is a used blade, you are applying a little more force. So the assistant has to specifically tell you that this is a very sharp and new blade. So you proceed very slowly. So especially for the beginners, when you are doing dissection, there is no hurry, because see, I don't think everyone will have to be completing so many hundreds of cases in a day like a Chitrakoot. So they can take their own time and do a slow and gentle dissection. Always see to it that the crescent is always seen through the scleral tunnel, and they can have a dissection. Second thing, the easier way of dissection is going radially every time and going little sideways instead of starting completely side to sideways, because side to sideways cutting is sometimes difficult and you can lose the plane. So have small wavy dissection, go from periphery to the center, again go to one side, again periphery to center, go to another side, again periphery to center. Because the scleral fibers also are readily located, this dissection becomes comparatively easier, because you are cutting less fibers of the sclera in this type of dissection. This is another tip I want to give.
Okay, very nice, sir. Because before I'm going to the incision, I will ask Dr. Ahmed about rexes. The preferred technique for the rexes when you are gonna do a case of intumescent cataract. The small rexes from the start, or the spiral technique, or what to do? To start with the small one and then to increase the width after, or what do you prefer?
For intumescent cataract, first I have two choices: either the spiral technique for the rexes, or just to fill the anterior chamber with elastic and just small incision start, and just to decompress the fluid from the bag and then complete the rexes. I tried from the start to be small rexes. Yeah. If I want to enlarge it, I can use for the anesthesia of the curved venous to enlarge it.
Okay, after aspiration of the material, which the fluidic or the fluids from the inside the bag.
Yeah.
Or or at the end? You mean at the end or after removal of the fluidics or the fluidy material from the bag itself?
No, better to after removal of some of the fluid, so they have no tension on the capsule. You can complete the rexes.
Yeah, to decrease the tension and to get the balance between internal and external pressures.
Yeah.
Right. Okay, Dr. Amolio.
Yep. Tell me.
The same technique, or you prefer another one?
See, usually you should do a small rexis and then extend it afterwards. That way it is much safer.
Okay, what about the spiral technique?
Spiral techniques are, what do you call the spiral technique? I don't know.
To start a small rexis, but don't end it. And when you about to end it, start another turn, and so.
Yeah, that's what I'm telling. That is you call it spiral, but that is what should be done. That is much better.
We are here calling it a spiral. What about Dr. Brahmani?
Yeah, we call it a spiral. Spiral is a very good technique. When you're scared of extension, always start with a very small capsular axis. Yeah. But when you're coming at the end, again go little peripheral and continue in a spiral-like fashion. But in spite of all our discussion, many times there are some tough cases. The moment the capsular axis needle touches the center, suddenly there are extensions on both the sides. It is very difficult to manage.
Okay.
Even I saw this envelope technique also is a good alternative for that.
Good alternative, yes, for that. But all the time we have to keep the anterior capsule flattened by the visco material because the main problem is the increased pressure inside. When you flatten and decrease the pressure inside, you will get safer rexes. I think so. Dr. Rakesh, you have any other recommendation?
In the intumescent cataract, we always prefer the two types of technique, as you say, the Dr. Amul Sahu and Doramani sir and Dr. Ahmed. We initially make a small rexis and then aspirate the few cortical material, then make a nick with the help of the bonus seizure, and then make another second rexis. It is very easy to make by any surgeon. Second rexis is the spiral technique. It is make a very small one and then not ended or not completed, just make a tangential fold. Before tangential fold, you put the visco in front of the and just behind the capsular tag. So push the rexis tag toward the center. Then pull the in the outside in direction. Then you can make a very spiral technique. And then I just prefer sometimes I very fast rexis. In the case of the intumescent, just make a nick and then very fast rexis. Sometimes you can make when you are experienced, then you can make very easily in this type of case. In the cases of there are the many techniques. They are the dimple, just press down technique. Just initially I said that just make an initial nick and then press the nucleus and then make a rexis very easily. So we reduce the pressure. This is the modified technique we can use in the intumescent cataract. There are the many techniques are available actually.
Yeah. Okay. Thank you very much. What about the phaco rexis? If we go to the phaco, not the small incision, what about the phaco rexis? You know this technique, the phaco.
Yeah, phaco rexis. Yeah.
Phaco rexis, yes. What about it? Is it does work?
It is not actually feasible actually, I think.
Yeah.
This is because sometimes when you go with the help of the phaco probe, just touch is gone away, both sides. It is very difficult.
But why are you giving so much of stress on the rexis?
Yes.
For a MSICS surgeon, the main important point is the wound construction. So rexis is nothing big deal for us. You know. Yeah. I think that those who are learning, they should focus on the wound construction. If it goes bad, everything goes bad. So therefore, the more stress should be how to construct a wound, and it should be really like I'm doing a 2 millimeter MSICS. So people have to go there and do a surgery which will compete with the best phaco surgeons. My son is a highly accomplished phaco surgeon. But my results, we have compounded the results, which is beat them phaco surgeon anytime. So we should be focusing there, the wound construction. And start with 6 millimeter, but aim to do it at 2 millimeter also, and let any phaco surgeon challenge, and then we'll show them the results. So that is where we have reached, and that is where we should focus. Rexis is not a big deal.
Yeah, okay, but actually it's very important step in the old cataract surgery.
But nowadays this is not a very important stuff because the new generation become very smart. So I think the all fellow can make a Rex very easily.
Okay, you are talking about yourselves. But really, Rexis is a challenging step to do it reproducibly, to be reproducible in doing your Rexis, not to every other case. Actually, we can do everything, but I agree with Professor Amalia to talk about the rules, the classic, but about the other options and the challenges you can do. But you keep yourself on the rules and on the safest technique for each. And then I will ask Dr. Brahmani about the incisions in the small incision cataract. What's the preferred location of the scleral incision from the limbs to keep it less astigmatic, and at the same time can handle the intraocular steps easily at the same time.
Osam, Boramani has developed an algorithm, and
Yeah.
can predictably, you can know that you are giving how much astigmatism will be there. And he is using all the high-end lenses, like toric lenses and all those things.
Yes.
So that is will be interesting for everybody. So you probe him on that.
Yeah, okay.
See, basically, the central part of the incision should be roughly about 1.5 to 2 millimeters away from the limbus for the ease of maneuverability. Now, what Dr. Sahu sir is telling is a different ballgame. It's not a part of today's seminar, but generally I customize all my incisions according to the pre-existing astigmatism, and then I'm able to neutralize right from 0 to almost 2 diopters of astigmatism. So I am putting the premium IOLs with more confidence, even multifocals with more confidence, because I know how much astigmatism I am going to neutralize. If patient's cornea is perfectly spherical, I don't induce any astigmatism, even with a scleral tunnel, and I don't require a 2 millimeter scleral tunnel. Even with 4 millimeter SICS, you don't induce any astigmatism. If it is a perfect U-shaped incision, and the ends of the incisions are far away from the limbus, because in the astigmatism only the central curve takes place. If the central curve is very small near the limbus, so that astigmatism is very small. It is smaller than the 2.8 millimeter incision on the cornea. So this way, by doing multiple surgeries, and secondly, again, the incision behaves differently in different quadrants. Like superiorly they behave differently, temporally they behave differently, and even in between, superior nasal, superior temporal quadrant, they behave differently. But after doing multiple cases with multiple shapes and multiple sizes of incisions in multiple locations, I have formulated my own algorithms, and most of the times they are working very well. Another advantage is that if I have to neutralize 1 diopter of astigmatism, and what I have a particular shape of incision, but if I fail by 0.5 diopters, instead of 1 diopter neutralization, if neutralization is only 0.5, still patient will end up only with 0.5 diopters of astigmatism. And if I overcorrect that with 1.5 diopters of neutralization, still the patient will end only with 0.5 on the other side. So that way it is quite advantageous. So, but I think this is a different topic of customizing the incisions.
Yeah, okay. It's an experience.
So I don't prefer the term SIA, the surgically induced astigmatism. For my method, it should be called as a SCA, surgically corrected astigmatism. Surgically induced astigmatism is like unwanted pregnancy. SCA is like a blind child.
Okay. Thank you. Thank you, sir. Very good guide for that. But the second question about the beginners, do you prefer to do it closer to the limbus to be easier for them. And the second point, use the blades instead of the newer one. Do you prefer that?
Instead of?
And to do or to create this scleral tunnel for the beginner, start closer to the limb first.
No,
yes,
no,
yes.
little.
Beginner can be, beginner has to see his comfort level. If he's very close to the limbus, maybe he has to put a single stitch there. But even 1.5 millimeter away from the limbus, beginner also can use that this technique. As far as the blades are concerned.
Yeah. Yeah, if it's closer to the limbus, it will be less tight, less clamped, and less watertight wound.
Yes, the valve mechanism may not work perfectly.
We can put the one suture in the beginner time. So initially we follow the straight incision.
Correct. Straight incision.
Always follow the straight incision and then put the one suture.
You can put one suture because as a beginner, then you don't bother about the astigmatism.
Yeah.
Okay.
First, learn the technique properly.
Yeah. Okay.
And then try to concentrate on the astigmatism.
But ideally, they should it should be incision should be away from the limbus, at least 1 or 1.5 millimeters.
1.5 millimeters it should be away from
1.5 is very okay.
So that way it will be a very stable structure.
Correct.
Yes. Okay. Thank you very much. What about the stepping of the transformation or transposition from the extra cap to the small incision, which I have shown in my videos? Do you agree, or you have any comments about that? To do a corneal incision first, then going to the scleral tunnel.
Now, if you are doing a corneal incision, it is not SICS. It is not a manual small incision.
No,
it is just a corneal
self-sealing corneal incision. This is the self-sealing, not a SICS. SICS means the small incision cataract surgery.
So
not a small incision. This is the ECC.
It means
Professor Hossam, you showed nicely that this was what you were doing earlier. Now you have come here. That is the way. And now you stick to teach your students the same way what you have not done shown the last video, because they should do always with the sclera, not go to the cornea.
Okay. It was just a step from 2.
Yeah.
A bridge.
So
actually, totally stop the ECC. So we just shift the SICS.
Start training only with the scleral tunnel incisions.
Yeah.
Okay.
In my institute, we totally stop the ECC. We just start from the SICS.
The moment you give them the easy way, they will never master the hard way.
Okay, but
so you don't stop that giving easy way.
Yeah. Okay, but the ECC should be everybody should know how to do ECC.
Yeah, let them take little time. Now there is no harm.
Okay, I'm with you. But all of the surgeons here start learning extra cap first, so they have to first, because it's the classic way. And about myself, I'm inventing the manual small incision cataract surgery in my practice and in the university, my university, Al-Azhar University, to be one of the steps every resident has to know about and has to do. After that, he can choose to do small incision or phaco. Yeah, the same.
No, but Hossam, I will come in. The moment they do a bad surgery like cutting the cornea and removing the lens, they will not feel proud as a SICS surgeon. They will always go for the phaco. Yeah. But if you are really making a scleral incision and doing that, and they see you doing that, they will always be interested in doing SICS because the result will be comparable. But if you are stitching, giving them stitch and all these things, what is the big deal? If why should I not do phaco? Why should I stitch my cornea? So that way we will be lowering the prestige of SICS. So
I pitched this 2 times in Egypt. So I just teach the SICS only. For the I'm part of the actually teaching in the Cairo University, and I did also the few surgery in the Dr. Ahmad Mustafa clinic.
Okay, actually in Egypt, the small incision cataract surgery is so prestigious. So it's like a magic surgery. because you can do in very short time without stitches at the end, and less costly at the same time. But actually, the small incision cataract surgery has the difficulty or the learning curve. It needs a learning curve to be optimized or to be mastered. Let me ask about the hybrid section. Do you prefer in the hybrid section, sorry, a delivery of the nucleus from the back into the anterior chamber? Do you prefer the hybrid section or the visco or the Senesky with the visco?
You want me to tell you?
During delivery of the nucleus from the back into the anterior chamber, it's one of the steps.
Yeah.
See,
Preferable to do it during
Hydroprolapse.
by rocking the nucleus from one side to flip the other side out, or to do that with a visco material, which is easier and safer at the same time.
see, what I do, you have to first make the nucleus mobile. You have to see that with a hydrodissection, you make it mobile and see that it is moving. If it is not moving, then there is a chance of your posterior capsular rupture. So what I do with my, I have a modified dialer. So I pull the rhexis margin towards myself, and then go behind the lens and nudge it into the front. And then once the one end comes out, and then you bring it out smoothly to the anterior chamber. There is no need for a visco pushing, because that way you will be creating a lot of pressure on the posterior capsule. There is no need for that.
Yeah.
So this is the way. This is just a nudge, and the lens comes out. So I will show you sometimes I will show you the technique. So that the dialer is modified, and what most of the time we have got dialer which is very long and very straight, and we can't do with that. You have to have a curved dialer and with a band tip. So I just pull out pull this margin, and then go behind the lens and nudge it to the front. So this is my way of doing things, and it's very easy.
Yeah. Okay. Okay. Thank you very much. What about Dr. Brahmani and your technique you have shown in the?
Yeah, I do it with a Sinsky hook. Generally, if there is side port on my right side, like say if the incision is superior one, the side port is at about 10 o'clock. So through side port, I pass a Sinsky hook, and in the region of about 12 o'clock, I go underneath the CCC and gently go up to the equator of the nucleus, and gently with the Sinsky hook, I lift the equator of the nucleus. But many times the nuclear diameter is bigger than the diameter of the CCC. So when we try to take out the nucleus, that time we have to do rotational movements, either clockwise or anti-clockwise, and gently the nucleus stretches the CCC and comes out. But this I would do with a single-handed technique. But many surgeons prefer two-handed technique under viscoelastics. They retract the capsular margin from one side, or maybe they depress the nucleus on that side and try to lift the other end of the nucleus up, and again hook the other side of the nucleus. And like you remove the tire from the wheelbase, like that rotational movement, you can take out the nucleus. Perhaps the two-handed method is more safe and it is less stressful for the zonules. But I do generally with a single-handed technique with a single Sinsky hook in my right hand.
Okay, thank you, sir, for this illustration. Finally, I want to ask Dr. Rakesh about the way by which you deliver the nucleus outside to get it out. Is it preferable to do it by pressure on the wound to get it out? In case of there's no anterior chamber maintainer, AC maintainer, like the video of Dr. Brahmani, in AC maintainer, the nucleus is pushed from inside to out. But if you don't have the AC maintainer, do you prefer the visco expression or to do it by the two instruments? Which is safer and easier, in your opinion?
I think the visco expression requires a slightly bigger tunnel.
Yes.
So for this region, I always follow the Bayer-Vectis, irrigating Bayer-Vectis technique. So just pull the rectus suture and then go behind the nucleus just up to the up to the pole, and then just press it and then remove the nucleus very easily. So I always follow this technique. Sometimes I do the visco expression with, in the cases of the very soft cataract actually. there's no need to actually remove with the help of the wire vectors. You can put the just remove the nucleus with the help of the visco. And I did not use the actually AC maintenance. Not use actually. I'm not any use actually.
Some surgeons are worried about hitting the endothelium during the sandwich technique by the Senesky. If I prefer to do that, how to keep the endothelium safe and away, and what's the direction? What is the direction of to do this technique safely?
See, basically what happens now, if you, there is no need for a sandwich technique. If you are you engage the nucleus, go behind, and first you push visco behind the nucleus and push visco above the nucleus. Then you create a space between the nucleus and the endothelium, and you create a space between the iris and the nucleus posterior surface. Place your vectis behind the nucleus, go to the end of it, see that you are not catching the iris in the 6 o'clock position, and then keep the position the vectis smoothly above the iris diaphragm, and then gradually glide it out. Then the pressure should be on the floor of the wound, not pushing the nucleus towards the endothelium. Many surgeons do that. To support the nucleus, they push the nucleus towards the endothelium, and thereby they spoil the endothelium completely. So what you do, you just engage the nucleus. So of course, in my vectis is a different thing, but in the normal vectis also, if you are having, then you engage the nucleus and gradually pressing the floor. You brought, once the nucleus get engaged in the your wound, then there is no problem of damaging the endothelium. So you gradually just pull it out, that it will come, and it should be a very patient procedure, not quick, not in a heroic way, but understanding all the time, visualizing all the time, knowing how much pressure you are putting, where it is going, everything. You have to be very, very artistic in your maneuvers. So the moment you try to be a hero, then you will end up being a zero.
Yeah, okay, perfectly answered, sir. Don't be hurried.
Oh, just a minute. I will come just. If you want to have a sandwich technique, what you can do, take a visco cannula. The visco cannula, you press the tip of the visco cannula, make it flat, and then put that visco cannula above your above the nucleus, and go on injecting this thing visco. You can divide that nucleus into 2 pieces and bring it out.
Yeah, okay. Thank you, Dr. Ahmed. Dr. Imad from Morocco raised his hand. Please, Dr. Ahmed.
Hello, Professor Hazem.
Hello.
Thank you for your this webinar, and thank you to all of your guests.
Okay.
I just want to know your experience all about SICS with trabeculectomy.
Trabeculectomy, yes. Okay.
Yes, and SICS in a situation with non-ophthalmia in small eyes.
The small eyes. Okay. Okay. Thank you, Dr. Ahmed, for this.
Thank you for
question. Thank you very much, Dr. Rakesh, glaucoma surgeon. Yeah.
Yeah, actually, in the cases of the trabeculectomy, we always go temporarily and make a straight incision, not need to make a curved incision, because sometimes during the nuclear delivery, sometimes it can cause the iridodilatation. So I slightly make a straight incision, then remove the nucleus very easily. And in the cases of the non-ophthalmic, I use the scleral tunnel, like slightly bigger incision, but you can remove by the same technique. Not need any precaution, actually, I think.
Okay, you mean, Dr. Rakesh, that you will do both techniques from the same tunnel?
Yes.
Okay, to remove the nucleus and do the trabecular, the scleral flap, and complete the formation of your tunnel and the bleb?
No. Actually, I just the bleb is present in the superior. We always make a tunnel in the temporal side.
Okay. To take another position for the scleral tunnel.
Yeah.
Perfect. Thank you very much. Dr. Bromani, Dr. Ahmed Mustafa, Dr. Amolia, do you have another answer about that?
Correct. No, the question was about the combined surgery, SICS plus trabeculectomy, isn't it? Yeah. So for combined surgery, my technique is
sorry.
Because I think Dr. Rakesh has replied for a pre-existing bleb
Post-trap
patient,
case.
Post-trap case. But I think the question was for SICS plus trabeculectomy. So I do SICS plus trabeculectomy at two adjacent sites, scleral incision on one side and trabeculectomy by side of that, but under one congenital covering.
Yeah. Okay. Thank you very much.
But you can do in the same incision also. You can do it.
Same incision, but I generally to keep both separate, but under one peritomy.
I think from the same tunnel will not be regular to be good working after that. Because of the scleral tunnel for the cataract surgery is not the same.
But if you are not controlled SICS surgeon, don't try in the same surgery, same incision.
Yeah.
If you are controlled, because you are going to make two layers there, and you are not perfect in your wound construction, don't do that. It is better to do in a two places.
And he talked about the non-ophthalmos, the small eyes. What's your experience about in such cases?
I don't have any experience.
In micro eyes.
So you unless you have got a smaller instruments, it will become difficult. So
Okay,
because the available.
We have talked before about the superior rectus hanging during cataract surgery, during the small incision cataract surgery, and all of us nowadays didn't are not using the superior rectus hanging in the surgery because of the severe or the dangerous complication which may happen from superior rectus needling, right?
Superior rectus, no?
Yeah, to hang.
We don't take.
That is a bridal suture of superior rectus. I think this is an unnecessary trauma to the eye. It is not required at all.
Yeah, okay, but in small eyes may be helpful for the exposure.
Maybe, but otherwise for a routine surgery, it is never required.
No, small eye, why should it be required?
But you agree, and for the temporal incision in the old cases or just in the trabeculectomy cases?
For any case, superior rectus suture is not required because in olden days, we were not having.
I'm not talking about superior rectus, but about the incision, the place of incision. Is it superior or temporal, or should be superior temporal only in the case of trabeculectomy? Your experience about the temporal scleral tunnel for small incision cataract surgery.
You're asking me?
Yeah.
See, for a routine SICS, my incision is exactly on the steep meridian. Whatever may be, if it is 134, I try to center the incision on 134. If it is 139, I try to center it on 139. So for that, I am doing the marking like using a toric IL marker for all my cases, so that there is no error of again 5 to 10 degrees when the patient is lying down. So that all your vector forces are now acting equally on the meridian, and whatever the customized incision is there will work very well on that meridian.
Okay.
So I go up slightly inferior temporally also. Say for example, in right eye, if the steep axis is 20 degrees, I operate on the 20 degrees, going slightly inferior temporal. If it is more than 20 degrees, if it is 30 degrees, then I go superior nasal.
No, okay, thank you very much, sir. Finally, I like to ask about the manual small incision cataract surgery in cases of subluxation. Do you have an experience about that? Either pseudoexfoliation cases, subluxated lens, or yes, Dr. Rakesh, raising your hand.
Actually, during the small incision, depending upon the subluxation or vitreous prolapse, if there the subluxation is the 1 or 2 clock hour, you can make a tunnel or not a problem, and you can make a rexus with the help. Initially, we actually try to initiate the rexus with the help of the cystitome. on the intact area, from the intact area and go from towards the journal dialysis area, and always make a slightly smaller access toward the journal dialysis area, and then always put the CTR. In the case of the dialysis is less than 2 clock hour, so you can put the 3-piece lens and put the haptic toward the actual dialysis area, and you can just reposition the generalize. If the more than 2 to 4 clock hour, I always the CTR. If the more than 4 clock hour, I always use the Sioni rings. In this type of cases, if there's any bacterial loss in between, you can cut it with the protector.
You didn't find any difficulty with the nucleus management in such case?
Yeah, this is the final. Actually, hydrodissection is very difficult. Sometimes the journal dialysis, so we can just support the capsule with the help of the capsular hook or iris hook, and then hydrate the nucleus and the prolapse from the intact area, and then put the visco and dial with the Sinski hook. So reduce the journular stress and prolapse then the nucleus in the antechamber, then deliver it very easily, and depending upon the hardness of the nucleus. Actually.
Okay, thank you. Perfect. Any other one of you of my dear speakers?
No, absolutely, I agree with Dr. Ragesh. All the forces in such cases should be from non-affected to affected area.
Yeah. Okay. Thank you very much. Really, the questions not stopping, but for the time, we have to save some of the questions for the coming meeting, inshallah. I'm so honored and pleased to have you today in this great meeting. Thank you for your time and thank you for your participation. Thank you, Professor Amolia Sahu, the founder and chairman of the International Society of the Manual Small Incision Cataract Surgery. Dr. Ramani, the executive chairman. Thank you very much for the International Society of the Manual Small Incision Cataract Surgery. Dr. Rakesh Shakia, the magic surgeon of the 2 minutes.
Thank you, Saud sir and Boramani sir.
Yeah, Dr. Rakesh, your surgery is required now in the COVID area.
And thank you.
Patients.
Patients take 3 inhalation, 3 exhalations. So today I did the 12 cases in the COVID area, but there are the many guidelines for I wear the 3 gowns and the mask, 3 masks actually. So it is very difficult to do.
No, but the OT time spent per patient inside the OT is minimal in your case.
Yeah, no, sir. So in between the in between the 2 cases,
you have to stop and take a break. That is okay.
Yeah.
Maybe patient taking 3 inspiration and 3 expiration, and patient is out.
Okay, I'd like to thank my professor, Dr. Ahmed Mustafa Ismail, professor of technology at Mansoura University, Egypt, and the past president of the Egyptian Ophthalmological Society and the board member too. Thank you, sir, for your presence here with us. And also, I'd like to thank Dr. Tahir Mohammed Gamal, keeping here with us today from the start till the end. Thank you, sir, and thank you for the audience, Dr. Imad. And
this is my professor in Mansoura, Tahir Gamal.
Really? Okay. I can ask him to unmute and share something with us.